Welcome. This video summarizes the critical protocols for glycemic control and insulin management in postoperative critically ill patients. Surgical trauma triggers a stress response, causing insulin resistance and stress hyperglycemia. This poor glycemic control is a major risk factor in the ICU. Effective glycemic control is crucial to reduce risks of surgical site infections, delayed wound healing, and higher mortality in critically ill patients. The standard target range for blood glucose in most critically ill patients is between 140 and 180 milligrams per deciliter. Tight glycemic control, targeting a range of 80 to 110 milligrams per deciliter, is generally not recommended due to significantly increased risk of severe hypoglycemia and mortality. Intravenous regular insulin is the standard of care for critically ill patients due to its rapid action and easy titration. Initiate a continuous IV insulin infusion when the patient's blood glucose level is persistently above 180 milligrams per deciliter, typically after 2 consecutive elevated readings. The standard concentration is usually a 1-to-1 ratio, 100 units of regular insulin in 100 milliliters of 0.9% normal saline. It is vital to prime the IV tubing by flushing it with 20 to 50 milliliters of the insulin solution, as insulin adheres to the plastic tubing. Effective management relies on dynamic, algorithm-based protocols rather than static sliding scales. Infusion rates must be adjusted dynamically based on both the current blood glucose level and the rate of change from the previous reading. Monitor blood glucose every hour upon initiation or after any change in rate. Once stable within target range, checks can be spaced to every 2 hours. IV insulin drives potassium into cells, so serum potassium levels must be closely monitored, usually every 4 to 6 hours initially, to prevent dangerous hypokalemia. Hypoglycemia is the most significant risk and requires immediate, standardized intervention. Hypoglycemia is generally defined as a blood glucose level below 70 milligrams per deciliter. If the threshold is met, immediately stop the insulin infusion and administer 12.5 to 25 grams of 50% dextrose in water via IV push. Recheck blood glucose in 15 minutes. Once BG rises above the target threshold, restart the insulin drip at a lower rate, often 50% of the previous rate. Patients can transition off the IV infusion once they are clinically stable, off vasopressors, and tolerating reliable enteral nutrition. Ensure the patient is clinically stable and able to tolerate continuous or meal-based nutrition before transitioning to subcutaneous insulin. The total daily dose is calculated based on the stable IV insulin requirement over the previous 6 to 12 hours. Use 60 to 80% of this amount for the initial subcutaneous dose. Critically, subcutaneous basal insulin must be administered 1 to 2 hours before stopping the IV infusion to prevent rapid rebound hyperglycemia.